I have no disclosures. Kuwait is a population of 4.9 million, of which 1.55 million are Kuwaitis. And this is the pool of patients that we'll be working with when we're trying to implant durable mechanical circulatory support system. This work presenting is done at Salman al-Dabbous Cardiac Center, which is one of the major cardiac centers in Kuwait, and we have championed the therapy of advanced heart failure since 2014. And I want to insist that all this work you see is a teamwork. It's not one person work, and this is very important. Let's do the mathematics here quickly. These are estimates, but if you look at the population of 1.5 million population, heart failure prevalence is usually 1.5 to 2%. So we see around 20,000 patients will be with heart failure, of which advanced heart failure is 10% of that, and reduced ejection heart failure, which is our subset of patients, is 50% of that. So, and the eligible people who are younger than 75 with no comorbidities will be around 230 patients. So we should basically implant 69 LVADs annually if we are doing the right thing. But last year, which is 2024, we implanted 14 LVADs. I'll come to the reason why. And the heart transplantation, we should be performing 23 transplants annually. Since 2019, I performed 5 transplants, and 2024, we've done 2 transplants. If we extrapolate this to the Gulf, we see that the Gulf of 56 million, we should be implanting 2,500 LVADs per year and 840 transplants. The transplants is difficult because unattainable because of the shortage of donors. However, the LVAD number we can increase. The reason is if you look at many interventional centers in the Gulf, hundreds, but you look at centers that implant LVADs are very small. So we have to increase the number of LVADs, and this will increase the number of and help a lot of people that need it. And I looked at the implantations done in the Gulf countries since 2019, and we see a total of 276 patients have been implanted in the Gulf. Before 2021, the therapy was half hardware, half heart-made, roughly in Kuwait, I'm talking. But since after the hardware was removed from the market, all our implants are heart-made 3. Let me take you through the hurdles we had to overcome in 2014. We were embarking on the therapy. First, we had to increase the awareness about the benefits of durable MCS and failure of guided medical therapy, ICD, CRTs, and TEER. And this took a long time because even some of the heart failure doctors, when you tell them we need to put the VAD, well, it's too aggressive, too aggressive. So, but we had to educate people on that. And as you know, Kuwait, like other Gulf countries, in the time, we were boarding patients for advanced heart failure therapies at that time. So our population that we had to attract were the people who were the sickest patients. And thus we had to bolster our MCS program to capture these patients. And in the last 8 years, we've performed 550 ACLSs, and this is in Addan Hospital and the Booth Center, of whom 297 were VA ECMOs. Some were weaned, some died, and the subset of patients that stayed on the ECMO are the ones that we were advancing to proceed to further therapy. We had to establish collaboration with international and European, American, and institutions for proctoring. Initially, we needed some proctoring, and that was stopped in 2017. As for the transplant of patients after the VAD is placed, well, we had to associate with American institutions to do that. Training healthcare professionals, and any country that needs to establish a mechanical circulatory support needs definitely support from the government, because these devices are expensive and need all the array of devices to be available at hand. You cannot go fight a war with one gun. You have to have all the machinery and weapons available. And we had to initiate a heart transplant program being faced with donor shortage. And this issue is becoming more and more important to us now because of 2 reasons. Number one, the LVAD survival at 5 years is around 58.4%, and that's approaching the 5-year survival of transplanted patients at 75. So LVAD is really starting to slightly compete with the gold standard in the past of transplant. The second thing we are facing now is that I have a lot of patients on VADs now, around 12 patients that need transplants. And since the change in the transplant allocation in the United States, Tier 1 are people who are ECMO Impella, and LVAD patients stable are Tier 4, so they will never get transplanted. I have patients fly every 6 months, they say come back in 6 months. So I think what I have to do is I have to really stress hard on doing the transplants in Kuwait, and maybe with the help of organ sharing donation in the Gulf, we can try to achieve that. Let me present our data, and this is our journey over a 10-year period, where 61 patients underwent 71 durable mechanical circulatory support systems. The male gender was 87%, the mean age was 52 years, and 86 years was the oldest, and after I checked with my colleagues everywhere, this was the oldest patient implanted in the world with a HeartMate 3. Our etiology was a little bit more than the typical etiology in the Gulf of ischemic 50%, ours was 67%, dilated cardiomyopathy 28%, 2 patients with aortic dissections, 1 had knocked his right coronary artery and developed massive RV infarct and ended with an RVAD, and 1, the whole heart was dissected and infarcted, and he ended with artificial heart. 1 pulmonary embolism that came acutely, but he had an antiphospholipid syndrome and he had chronic recurrent embolisms before. So I took him to the operating room, did pulmonary embolectomy, thromboendarterectomy. However, his RV was not recovering. He was placed on RVAD for 15 months and he was explanted, and he's doing well. As for device implantation, 46 were isolated LVADs. RVAD was 3, BiVAD 6, and HeartMate 6 were 2. But as Dr. Natuka mentioned, I think we believe that if you leave the native heart, it's much easier to manage these BiVADs. And we had 4 syncardians and 1 redo RVAD. Our intermax was, as you see, the sickest patients. 85% of the patients were intermax 1 and 2. And these are the sickest patients in the literature. Our 30-day mortality was 26%. Our 1-year mortality was 57%. This translates is a 1-year survival of 43%. This is a low survival, but I will allude to it in the next slide. So as of December, as of today, we have 34% of the patients are alive, 7 have been transplanted, 1 has been retransplanted, 2 patients explanted, and 12 patients on the waiting list, 9 at home, and 3 in the hospital. So I had to go to literature to see what are these sick patients doing all over the world. And I had 2 great papers from the charity group Berlin Heart. One where they took 100 patients on ACLS and took them to an LVAD, and their survival was exactly like mine, or mine was exactly like them. So I was really shocked. And another paper published recently of a randomized trial or multi-center trial of 531 durable devices placed from ACLS, and their 1-year survival was 53%. So these are the sickest patients, and they have low survival. And in the Berlin paper, it was noted that duration of ACLS, more than 7 days, was a bad outcome for survival. Also female gender and people who are high BMI. Another paper published from multi-center trial showed that the survival was much better when you proceed from LVAD, from Impella rather LVAD from ACLS. And we see the 1-year survival when you go from Impella to LVAD is much better than the survival if you go from ACLS. And this is this year's implantation. 24, we implanted 12 patients with 14 devices. And if you look, I don't want to bother you with the stable, but a lot of our patients have been converted from Impella to LVAD instead of from ECMO to LVAD. And my 30-day survival is 100%, which is great. So this is, I will go with you through a small case that we got this month. I wanted to keep it hot off the press. 42-year-old male with dilated cardiomyopathy. He was morbidly obese, 151 kilograms. His past history showed subcutaneous AICD. He had recurrent PEs, and in 2014 had an IVC filter placed below the renals. His INR admission was 3.5. He was transferred from a major general hospital, and he's been there for 1 month. He's been there for 1 month. They were dealing with gargenic shock, septic shock, urosepsis, and this is the problem we are facing in my center. When the patients are referred to us, they are referred at the last stage. And if we can get them earlier, we will give them a better job. When we saw him in the hospital, he was dizzy, short of breath, his systolic blood pressure was 80 millimeters. He was on high inotropic support, vasopressors, acidemic, he was an atrial fibrillation, he was anuric, and the CVP was 38. His echo showed severe biventricular dysfunction. And this guy, probably I should put an auxiliary 5.5 in him, but we could not even hold the patient hand. He would arrest. He was struggling, short of breath. So my initial thing was to proceed to take him to the operating room, to the cath hybrid operating room, and after we've given vitamin K and 4-factor PCC, converted his INR to 1.3, he was anuric, so put a dialysis line. I inserted a left ampullary CP 3.5 to stabilize the patient. Obviously, we couldn't go femoral vein because of the previous umbrella placement, so we went internal jugular above the umbrella, and we did a right femoral ECMO with distal perfusion. His LVEDP, when we were planting the ampulla, was 40. And with that, I could stabilize the patient to be able to really intubate the patient safely. Because if this patient was intubated, he would have arrested and died, and you cannot bring him back. On 4th of November, I took him back to the hybrid where he was intubated and ECMELLA 2.1. ECMELLA 2.1 is an ampulla 5.5, ECMO and an auxiliary placement, and the venous canal in the neck. And this will be important for us for later management of the patient, because then you can ambulate the patient. And this is a slide when we were exchanging the ampullas, and this is an ampulla 9, 3.5 plus 5.5. The patient continued to do well. He was extubated, and the ampulla was doing well. He was mobilized. He lost 30 kilograms of weight over 3 weeks. Because if I took the patient immediately when he arrived, he would have never made it out of the operating room. And this is with permission of the patient, is himself, after the placement. I don't have sound, but he's asking how you're doing. He says, I'm doing very well. After he was stable, on November 24, I took him to the operating room where an LVAD, RVAD, closure of PFO, and LA appendage clipping was done. The patient was doing extremely well, extubated December 2nd, and we were all happy, everything is fine. Unfortunately, not all stories end happily, but it's not ended yet. On December 6th, he developed vesicular rash over his body. December 7, he had reduced level of consciousness. He was seen by the neurologist with a diagnosis of varicella encephalitis. And this was entertained because the culture of the lesion showed varicella zoster. December 10th, his mental status worsened. He was intubated. Emergency CT of the brain showed brain edema, subarachnoid hemorrhage with enlarged ventricles, and we drained the CSF. And the CSF fluid showed varicella DNA in the thing. IV acyclovir was started. The patient is now sedated, and as of today, he's still not fully awake. And I think this guy will do well. I mean, we've seen many patients with ECMO, subclinical subarachnoid hemorrhage. We've even operated on VADs on patients with stable subarachnoid hemorrhage who was awake. So I think the story is not out yet on this patient, and I know that if that encephalitis, which may take 1 week or 2 weeks to be controlled, I think he will do well. In conclusion, they changed our practice of not taking patients on ACLS directly to the durable mechanotherapy has been a game changer. We try to stabilize the patient with Ampulla 5.5. We wean the ACLS in 3 to 4 days if it is possible. We proceed to durable mechanical circulatory support semi-electively. This translated to a much better survival, and practically since 2021, I did not need to place a temporary RVAD in patients who end on an LVAD. We never give up. Thank you very much.